So suppose this is our small intestine, right? Suppose this is our small intestine and this is our systemic circulation. So arteriovenous circulation or systemic circulation, right? Now, whenever we eat food, carbohydrates, we can eat carbohydrates in its simplest form. And in its simplest form, that carbohydrate, it is called as glucose. And if I eat glucose, there is nothing to stop glucose from getting absorbed. So glucose can easily get absorbed into my systemic circulation. And for this, we have receptor here, the receptor present for absorption of glucose here. This is called as SGLT1, right? So sodium linked glucose transporter 1, it is an active transporter which absorbs glucose. But if I consume complex carbohydrates like starch and disaccharides, we humans do not have the capability to absorb them. So what God has given us an enzyme that can break down starch and disaccharides into glucose with the help of an enzyme. And that enzyme is called as alpha glucosidase. Now, once it is broken down, now again the receptor comes into play here is the receptor comes into play here is SGLT1 that would absorb glucose, right? That would absorb glucose. Now see, if glucose is absorbed into systemic circulation, why glucose would be required by the systemic circulation? Because suppose this is a cell we have, and all the cells in our body, they require glucose for generation of ATP. And for that, to take glucose inside, they have a receptor called as GLUT4, but it is present inside. So if glucose is absorbed and GLUT4 is inside, there would be significantly high blood glucose level, and that would be called as severe postprandial hyperglycemia. Now, it would be a problem, severe postprandial hyperglycemia, because glucose is osmotic in nature. It would pull all the water out of your cells, flood your blood vessels, right? You'll have congestive heart failure, your neurons will be dried, and you'll have neurological deficits every time you have food, just imagine. But that does not happen because our body has a mechanism in place. And what is that mechanism? See, the glucose, as soon as it is absorbed into the epithelial cell, right? In this epithelial cell, it increases production of few things. And these are things like GIP or gastric inhibitory peptide and GLP-1. Now this GLP-1 is glucagon-like peptide 1. GIP is gastric inhibitory peptide, right? GLP-1, it's metabolized in plasma by an enzyme called as DPP4. Now see, why am I telling you that it is metabolized in plasma? The reason being, this is something I've discussed earlier in autonomic nervous system, anything that is metabolized in plasma has a very short half-life, right? So GIP and GLP-1, see, these two, once they're released, so see just what's happening. Even before the blood, the glucose is reached to the blood, these two are released into plasma and they go into the pancreatic beta islet cells where we have GLP-1 receptors plus I do have GIP receptors as well. So what happens? This GIP will bind to GLP-1 receptor, GIP receptor. GLP-1 will bind to GLP-1 receptor. Now, stimulation of these receptors on the beta islet cells, it leads to release of two things. Number one, there is release of insulin, and number two, there is release of amylin. Now, why these two peptides are released? So even before glucose is released, insulin is being released, and this insulin which is released is only for a small period of time, right? Very small amount of insulin is released. Why? Because GLP-1 and GIP-like peptides are very short-acting peptides as they are metabolized in plasma. No matter whatever is the amount of insulin released, there is a receptor for that insulin present on our cells, and that is called as insulin receptor. So this insulin comes and binds to the insulin receptor, and that brings the GLUT4 receptors out. That brings the GLUT4 receptors out. Now see, by the time all of this is happening, the glucose is gradually moving forward and the glucose reaches into systemic circulation. So by the time glucose reaches into systemic circulation, my GLUT4 receptors are out to welcome the glucose. Please come in and make some ATP. Now glucose moves in, and this is the mechanism by which I try to decrease or curb the postprandial hyperglycemia, right? Now, the postprandial period is over. Even after the postprandial period, glucose would still be getting absorbed. Now, this glucose concentration which is rising after the postprandial period, this rising glucose concentration would be sensed by the GLUT1 receptors present in your beta islet cells. And these GLUT1 cells will take these glucose in. Now, how much glucose will move in, it would depend upon how much is the glucose concentration more in plasma as compared to the cells. Why? The reason being, GLUT1 receptors are facilitated receptors. That means they cause facilitated diffusion. So the movement of glucose is concentration dependent. So whatever glucose is in excess in plasma as compared to cells, only that amount of glucose will move in. Now, whatever is the amount of glucose moves in, that is the amount of ATP generated. So the amount of ATP generated corresponds to the amount of glucose that moves in, and the amount of ATP generated would correspond to the block of number of ATP sensitive potassium channels in the beta islet cells. And now, whatever be the number of ATP sensitive potassium channels being blocked, that would correspond to the amount of insulin release. So, if I join the first end and the last end of thread, I would understand that what is the amount of insulin release? It actually depends upon what is the amount of glucose present in plasma. I mean, what is the excess glucose? Now, if this mechanism was not present, every one of us would die of hypoglycemia by release of unusual amount of insulin, right? So guys, this is how our body takes care of glucose. So this is the basic homeostasis of glucose. This is not pharmacology. This is physiology. This is more important for the second year students. There are no MCQs here, let me tell you, right? So if you need PG aspirant or ionized aspirant, you're searching for MCQs, no. This is not for MCQ. This is to make you understand the concepts. One thing I can do is I can just make you cram the drugs. Second thing I can do is I can make you understand. Now, if you know this much, you'll have a lot of idea about how the drugs act. Let me end this story of glucose by the second source. So this is one source of glucose, that is when I am having food. What if I'm not having food? If I'm not having food, if I'm fasting, for example, in that case, an organ takes over. That organ is called as liver. And liver, there is gluconeogenesis. It can also contribute to the blood glucose level. So another source of glucose is gluconeogenesis. All right. Third physiological link here is this one. Let me ask you something. Just think. Do we humans filter glucose in the glomerulus? Yes or no? The answer is yes. All of you know that, right? But do we lose glucose in urine? No, right? Why? Now, what is that? If it is filtered, why it is not lost? The reason being, let us have a look at another organ here, and that organ is called as kidney. So as in the kidney, suppose this is the renal tubule. So as we had SGLT1, we have SGLT2 receptors present in the kidney. And the SGLT2 receptors, these are active transporters. So SGLT1 and SGLT2, these are active transporters which will reabsorb all the amount of glucose that is present, right? All right, so now this is the complete story of glucose homeostasis. And now that we are done with this, let us try to understand how these drugs act. All right, before I move on, I forgot to tell you one point. GLP-1, what is one of the functions of GLP-1? See, GLP-1, it releases insulin. That is one function I told you, right? Apart from that, this GLP-1 and amylin both have another function, and that is both can decrease contraction of your gastrointestinal tract. In other words, amylin and GLP-1 will delay gastric emptying. All right, guys, if I'm delaying gastric emptying by GLP-1 and amylin as well as GIP, what is the role of delaying gastric emptying in glucose homeostasis? Just think, you know the answer. Now tell me something, if gastric emptying is delayed, right? So I'm just drawing it here. Don't write it. This is just to make you understand, right? If the food is here, and if I delay the gastric emptying, then the blood glucose level will rise faster or slower. So if I delay the gastric emptying, now if this was the rise in blood glucose, if I delay it, this is how the blood glucose will rise in the postprandial period, which means what? Again, by delaying gastric emptying, what happens is food remains in the stomach for a very longer period of time. And it is slowly released, so it also dampens postprandial hyperglycemia. So these are different mechanisms by which GLP-1, GIP, amylin, they helps us to curb the hyperglycemia in the postprandial period. All right, we're done with that. Now let us have a look at the drugs. What are the possible drugs that can be used for treatment of diabetes mellitus? Number one, let us begin from the starting of the story. What I can do is I can give a class of drug, number one, which can block conversion of starch and disaccharides into glucose. And these are called as alpha glucosidase inhibitors. Okay, fine. Let us try to understand this. Alpha glucosidase inhibitors, where are they acting? Where are they acting? Yes, where are they acting? On starch and disaccharides. Where are starch and disaccharides present? Where are they present? In the food. Okay, so they will act on the food, right? They will act where? On the food. So when should I take them? Before food, after food, during food intake, right? In offline classes, most answers that I get is before food, right? But that is not the right answer. We take it during food intake. So what I tell the patient, take the drug after a few bites of a chapati or a few spoons of rice, so that it will act on the food, right? So I should not give it before food or after food, during, in the midway of food intake. That is one point, right? Second, what can I use it for? Postprandial hyperglycemia or maintenance of diabetes mellitus. See, all of you, if you're a second year student, you will not be aware of what is the meaning of this. What I'm telling you about this, let us see. Suppose this is, don't write this, this is just to make you understand. This is the plasma glucose level, and this is the moment when I had food. At time 0, I had food. The moment I have food, what happens? My blood glucose level will take a peak, and then it would come down and down and down. And this is when I would be hungry again, right? And again, I have to eat food here. Now, this is normally what happens, and this is called as postprandial hyperglycemia, right? So if you're not a diabetic, your postprandial hyperglycemia would be within normal range, and your blood glucose level will be within normal range. Now, what if you're a diabetic patient? Suppose there is a patient of diabetes mellitus. In that patient, what happens? Whenever he has or she has food, the plasma glucose level would shoot up and would be high throughout the day. This is what happens. So there is severe postprandial hyperglycemia. So what is that I need to treat in diabetes mellitus? I need to decrease this postprandial hyperglycemia. So first, I need to treat postprandial hyperglycemia. That is one, first point, right? Second, I need to bring down the blood glucose level throughout the day, and that would be called as maintenance. I need to maintain the blood glucose level. So I told you this is more important for the second year students. If you're an intern or post-intern, you know about these things, right? So these are two aims. Now what I'm about to ask you is, tell me something. This alpha glucosidase inhibitor, the class that I'm talking here about, the alpha glucosidase inhibitor, will it be used for postprandial hyperglycemia or will it be used for maintenance? Think. I want you guys to think and find the answer yourself. Think, what is the answer? Will it be used for postprandial hyperglycemia or will it be used for maintenance? The drug is acting on the food. Mind it, the drug is acting on the food. So obviously, it would be used for what? Postprandial hyperglycemia. See, don't worry. I'll make you write all of this. But before making you write all of this, I'm trying to make you understand the concept behind this, right? So alpha glucosidase inhibitors, they are taken in between food for treatment of postprandial hyperglycemia. What could be the side effects of alpha glucosidase inhibitors, guys? Just think, if I give alpha glucosidase inhibitors, what is going to increase in our intestine? Starch and disaccharides. Okay. We cannot absorb starch and disaccharides. These starch and disaccharides will reach to the colon, and in colon we have a huge colony of bacteria waiting to feast on these starch and disaccharides. They will feast, they will have party and generate a huge amount of gas. You will be bloated, and that side effect is called as flatulence, right? So these drugs, alpha glucosidase inhibitors, they cause flatulence, number one. Number two, starch and disaccharides are osmotic in nature, means they will pull water into the colon, and that would cause osmotic diarrhea. So all of these I'll make you write later, right? Here, I'm trying to make you understand the concepts which nobody will make you understand. Books, they do not make you understand all of these, because books will not correlate this physiology to pharmacology. That is the job of a teacher. That's what I'm doing, right? Second, we have designed drugs which are agonists of GLP-1. So GLP-1, these are called as GLP-1 agonist. These are called as GLP-1 agonist. Now, GLP-1 agonists, whenever they act upon GLP-1 receptors, they will release insulin, and that can take care of diabetes mellitus. Now, these are used for maintenance of diabetes mellitus. Or what I can do is, to increase GLP-1, I can block DPP-4. So there are two classes related to GLP-1. One is GLP-1 agonist. One is DPP-4 inhibitors, right? One is DPP-4 inhibitor. So these are two classes related to GLP-1. These are called as GLP-1 related drugs, GLP-1 agonist, DPP-4 inhibitors. Now coming to a latest class of drug, and this is called as a dual GLP GIP agonist. This is a dual GLP-1 and GIP agonist. So this is a third class of drug, dual GLP and GIP-1 agonist. Third class of drug, new class of drug is there. Which drug is it? I'll talk about that later. So all these drugs, they can be used for maintenance of diabetes mellitus. Now, what could be the problem with these drugs? Let us try to understand. Now, first of all these drugs, they are acting upon beta islet cells, right? They're acting upon beta islet cells. That means they'll be used if in diabetes mellitus beta islet cells are present. That is only type 2 diabetes mellitus. They cannot be used in type 1. They can be used in type 2 diabetes mellitus for maintenance, right? What is one of the worrisome side effects about these drugs? See, these drugs are acting upon beta islet cells, and they would irritate the beta islet cells, and all of them, they have the ability to cause pancreatitis. Some drugs more, some drugs less, right? So there's the common thing about these drugs. All right, now, second point that is important here is number 3, what I can do. So number two classes I've discussed. Number 1, these are drugs, alpha glucosidase. Number 2, I've discussed these are drugs related to GLP and GIP-1. Number 3, I can use a drug called as amylin, and I can use analog of amylin. I can use amylin analog, right? Now see, if I use amylin analog, how is it going to act? Simple, it is in front of you. It is going to block or delay the gastric emptying. How amylin analog is going to act? Amylin analog is going to delay the gastric emptying. Now, if I delay the gastric emptying, then what happens? The plasma glucose level after having food will rise slowly. So here, this would be the effect of amylin, right? That means amylin analog would be used for what? Maintenance or postprandial hyperglycemia. For what? Obviously, postprandial hyperglycemia. Amylin analog is used in postprandial hyperglycemia. So remember, 1 and 3, these are used in postprandial hyperglycemia, right? All right, guys. Now, number 4, I can directly use insulin, right? I can use insulin as a drug as well. So I can directly use insulin as a drug. I can use insulin as a drug, and it can be used for maintenance as well as postprandial hyperglycemia, both in type 1 and type 2 diabetes mellitus. Number 5, what I can do is I can give oral hypoglycemic agents which increase insulin release. Now, how these drugs increase insulin release? How? The answer is above. By blocking the ATP sensitive potassium channels. If I block ATP sensitive potassium channels, they will release or increase the release of insulin. So they increase release of insulin by blocking ATP sensitive potassium channels, right? And so this is our 5th class of drug. I can release insulin. I can release insulin, oral hypoglycemic agents that can release insulin. So whatever I've told until now, guys, there is one thing I want to make you understand here, and it's a very golden concept. It's a golden concept, very important concept where MCQs are commonly asked. And what is that concept? See, this class number 5, class number 4, and class number 2. There is something common with these 3 classes. So what is that is common with these 3 classes that I'm talking here about? I marked in yellow color. What is common? What is common? Apart from yellow color, what is common? What is common? What is common? What is common? Think, come on. These are the drugs, all of them, they act via insulin. Either they're insulin or they increase release of insulin. Now remember the golden rule: to cause a side effect called as hypoglycemia, the drug must be insulin or it must release insulin. And it is maximum with insulin that is understable. It is maximum with insulin followed by drugs that release insulin. It's a golden. So they ask you, which of the following drug will not cause diabetes mellitus? Right? Which of the following drug will not cause hypoglycemia? And your answer is most of the times a drug like pioglitazone or metformin, which have nothing to do with insulin. You got my point, right? All right, so this is number 5. Okay, number 5. Number 6, guys, what I can do here? Number 6, what can be done? Number 6, what I can do is I can act upon insulin receptor. Okay, what can I do here? Okay, I can give oral hypoglycemic agents that decreases insulin resistance. I can give oral hypoglycemic agent that can decrease insulin resistance. So this is 6th class of drug. So with the same amount of insulin, more number of GLUT4 will come out, right? So here we have drugs like pioglitazone, which I'll discuss later. Number 7, what can I do here more? What can I do here more is, okay, number 7, I can act upon liver and I can block. So I can give OHA that can block gluconeogenesis. And it would block the hepatic glucose production. So the glucose that is made from the liver would be blocked, right? And gluconeogenesis is blocked. So blocking of hepatic glucose production, the most important drug here which acts upon metabolism of glucose, metabolism, metformin. Again, I'll talk about that drug in a short while. The last one, number 8, I can give oral hypoglycemic agents that can block SGLT2 blocker. Now, if I block SGLT2, what happens? I would block reabsorption of glucose from the kidney. The latest class of drug, number 9, it blocks both SGLT1 and 2. So number 9, these are OHAs, which will block not only SGLT1 but also SGLT2. This is a drug that was approved in 2023. It is called as sotagliflozin. I'll talk about that drug as well.